Hi everyone, my name is Dr. Obeng-Frimpong and welcome to my channel where I teach and simplify medical topics or concepts. Now, headache is a very common reason why we all seek medical care. How do you know the cause of your headache 2 days ago, or how do you arrive at the diagnosis of your patient's headache? That is going to be our discussion today. Stay tuned, and if you like the content, feel free to give us a like, share and subscribe to our channel, and please do not forget to turn on your notification bell as well. Good. And so headache is one of the most common reasons patients seek medical attention. And what is the cause of headache? Headache is due to the activation of pain-sensitive structures in and around the brain, the skull, the face, sinuses, or the teeth. It means the head is made up of pain-sensitive structures and then pain-insensitive structures. And so when the pain-sensitive structures are activated, they produce headaches. Meanwhile, when the pain-insensitive structures are activated, no matter what, they won't produce headaches. And so kindly take note of the origin or the pathophysiology. Now, the pain-sensitive structures in the head outnumber the pain-insensitive structures. And so let's look at the pain-insensitive structures. Then when we know them, we can guess what the pain-sensitive structures are. And so we want to remember them with the mnemonic BEDCAP. BEDCAP, B-E-D-C-A-P. And so B stands for the brain parenchyma itself. It is not really pain sensitive. Then we have ependymal cells. Ependymal cells are one of the glial cells in the brain which helps produce the CSF. Then we have the dura, which covers the convexity of the skull. The dura, which covers the convexity of the skull, which lines the skull, is described as pain insensitive. But the dura, which is part of the meninges, so we have the periosteal dura and then the meningeal dura. The meningeal dura is rather pain sensitive, but the dura, which covers the convexity of the skull, is pain insensitive. Then we have the choroid plexus. So the choroid plexus is the body which lines the ventricles. And then they have the ependymal cells within them. They secrete or they produce the CSF. Then A for arachnoid matter. So arachnoid matter is the middle layer of the meninges. All those literature really disagree on this point. Some think that the arachnoid matter is pain sensitive, others think that it is pain insensitive. So I have added it to the pain insensitive structures. Then P stands for pia mater, the innermost layer of the meninges. So these 6 are considered pain insensitive. So apart from them, any structure within the head is pain sensitive, and so when it is activated, the sensory nerve endings will carry impulses to the brain to be interpreted as pain, which would give you headache or facial pain. Now, when a patient presents to you with headache, what are the possible causes of this patient's headache? There are myriads of causes, but we want to use a mnemonic to remember or to group the various causes of headaches. So the mnemonic is vitamin D and E. That is the mnemonic used to generate differential diagnosis of a condition. And so V will stand for vascular causes. We will see them in a jiffy. I stands for inflammatory or infectious causes. T stands for traumatic causes. A stands for autoimmune causes. M for metabolic causes. I for idiopathic. Now I put it in light green because of a reason I'll share later. N stands for neoplasia. Then D in the mnemonic stands for drugs. And lastly, E stands for everything else or endocrine causes. Now, primarily or basically, headaches can be grouped into primary headaches and then secondary headaches. In pathology, idiopathic means, or if a condition is considered idiopathic, it means that its underlying cause is unknown. And in pathology, idiopathic can be described using various terms, which I have mnemonicked as SPICE. It means in place of idiopathic, you can use spontaneous. Sometimes idiopathic conditions are described as spontaneous. Another synonym is primary. Then the I, of course, stands for the idiopathic. Then C stands for cryptogenic. And then E stands for essential. It means that, for example, hypertension, primary hypertension can be described or can be termed as idiopathic hypertension, can be termed as essential hypertension. All these are synonymous pathological terms. So, in the mnemonic, vitamin D and E, idiopathic causes are primary headaches, and then the rest, aside idiopathic causes, are secondary headaches. And so please bear in mind that headaches can generally be classified as primary or secondary. And so let's begin with the mnemonic V for vascular. And so what are some of the vascular causes of headaches? So one, we can have strokes. So it can either be ischemic or hemorrhagic strokes. Another vascular cause of headache, we can have subarachnoid hemorrhage. Then we can have idiopathic intracranial hypertension. Another cause here would be cerebral venous thrombosis, and what I want to highlight is cavernous sinus thrombosis. Then another cause, we have carotid or vertebral artery dissection as a cause or as a vascular cause of headache. And of course, we have an acutely elevated blood pressure, and so malignant hypertension or accelerated hypertension affecting the cerebral vessels can give you headaches. And so these are the few vascular causes we can think about: strokes, subarachnoid hemorrhage, idiopathic intracranial hypertension, cerebral venous thrombosis, particularly cavernous venous thrombosis, carotid or vertebral artery dissection, and then acutely elevated hypertension or accelerated or malignant hypertension. We are thinking of inflammatory. So the inflammatory causes, essentially they are infectious causes. And so we are asking ourselves, what infections can occur in the brain which can give you headache? And so you have meningitis, the dura mater or the meningeal dura. If irritated because of inflammatory processes, it can give you headaches. We have encephalitis. So if the brain and then its surrounding structures are irritated, encephalitis can give you headaches. You have cerebral abscess. You have sinusitis. So the various sinuses like the frontal sinus, the ethmoidal sinus, the maxillary sinuses, when they are all irritated by inflammation, you can give or you can have headaches. Then we have dental infections. So we have gingivitis or pericoronitis, or any dental infection can give you severe throbbing headaches. If you've had a dental infection before, you will see that that is one of the most common causes of severe headaches. Then, of course, general infections like malaria. Then you can have a collection of pus below the dura mater, said that it is irritating the dura mater. So that is a subdural empyema. You can have headaches as a result of that. You can have ear infections. The ear mucosal membrane is irritated. It can give you headaches. Then we have viral infections in general. So non-specific infections can also give you headaches. And so you see that right from, or even using V and I, we've been able to generate a considerable number of differentials for headaches. T for trauma, and so traumatic causes like traumatic head injury. You can have epidural hematoma, subdural hematoma. All of these can give you headaches. Then we have A for autoimmune, and so autoimmune, we have vasculitis, cerebral vasculitis. So the arteries are also pain-sensitive structures, and so when they are irritated as a result of inflammatory processes, they can also give headaches. Then we have metabolic, M for metabolic, and so metabolic causes anything that causes increased carbon dioxide, so hypercapnia. decreased oxygen tension, hypoxia, and even carbon monoxide poisoning can also give you headaches. And so remember that the ones we've talked about are causes of secondary headaches, or some causes of secondary headaches. The next I is idiopathic, and like we explained earlier, idiopathic can sometimes stand for primary. So the primary causes of headaches, or yes, we have migraines, we have tension type headaches. Tension type headaches are the most common cause of headaches in general. If a patient comes to you presenting with headaches, your best bet is that it is likely to be a tension type headache. Then another form of primary headaches, we have the trigeminal autonomic cephalgias, of which cluster headaches are part. There are other causes of this cause of headache, trigeminal autonomic cephalgia, but we want to stress on cluster headaches. And there are also other causes of primary headaches, but we want to just settle on these three: migraines, tension type headaches, and then trigeminal autonomic cephalgias. Then of course, N, we come back to another secondary cause of headache. N stands for neoplasia, and so we have neoplastic lesions like primary brain tumors. We have brain metastasis and other intracranial tumors like pituitary tumor, meningiomas. When they compress on surrounding structures, they may cause headache as a result of probably a raised intracranial pressure. Very good. And so please do not forget to like and share this video if you like the content you are watching, and then subscribe to our channel. Please do not forget to hit your notification bell so that when we post new videos, you will be notified and then enjoy free content. Now, D stands for drugs, vitamin D and E. D stands for drugs. And so drugs, we have analgesia overuse. When a patient abuses analgesia so that he gets past his tolerance level, now he starts having headaches. We have nitrates. Nitrates are also known to cause headaches. Estrogen containing drugs like combined oral contraceptive pills can sometimes cause headaches. Then we have antihypertensives like calcium channel blockers, including nifedipine, amlodipine, can cause headaches. Then we have proton pump inhibitors. Some literature document that proton pump inhibitors like omeprazole can occasionally cause headaches. Then E stands for endocrine causes, or everything else. And so we have glaucoma, giant cell arteritis, temporomandibular joints disorders. So all these can cause headaches. So when we use this mnemonic, you see that we can generate quite a considerable number of differentials for headaches. So when our patient comes presenting with headaches, I wanted to say, or I should have said, we should use this and then completely evaluate them to see if they have any of these conditions, bearing in mind that tension type headache is the most common cause of headache you should be looking out for. Very good. Now, one of the things to do whenever you are meeting a patient with a complaint is to generate your differential diagnosis based on the patient's age and the patient's sex and the patient's other factors. Once you see a patient, listen to the patient's presenting complaint, naturally you have some differential diagnosis coming into your head. And then luckily we've had a mnemonic that explains differential diagnosis of headaches. So the first thing you do is you take a history, and for the history you are focusing on the demography, the age, and then the sex of the patient, because obviously you wouldn't consider migraine in a 4-year-old first, would you? No. And then probably for a male, between migraine and then cluster headaches, you would probably consider cluster headaches first. And so the age and then the sex sometimes, or not sometimes, but really play a role in determining the cause of your patient's headache. Then the history of presenting complaints, you want to ask if there has been a history of headaches, prior headaches like this, because primary headaches tend to be recurrent. They tend to patients come with recurrent episodes, whilst most secondary headaches are probably new onset or a change in headache pattern. And so you want to ask that. Of course, you want to ask if there was, I wanted to say if there is any past medical history, if the patient has been diagnosed with any condition in the past before, because that condition may have a link with, the patient's complaints. Consider a patient who has hypertension. Then if that patient comes with headache, you are really concerned, right? Then you want to do the Socrates of the headache. And so where is the headache located? Did the headache come gradually or suddenly? The characteristics of the headache, is it throbbing, or it is constant, or it is pressure-like? Does it radiate anywhere, like coming down the neck? Are there any associated symptoms? What is the timing of the headache? What triggers the headache? Anything the patient does to worsen the headache, and then the severity of the headache. You want to know all these things. And then the ODQ, the underwrite questioning. We've said it countless times on this channel that the ODQ focuses on the cause of the presenting complaint. And so here you ask for relevant diagnostic symptoms and risk factors that can point to the possible cause of the patient's headache. And then whilst you are asking for these symptoms, you want to be noting red flag symptoms. Now, red flag symptoms, we'll take a look at them in the subsequent slide, but red flag symptoms are symptoms which are also known as danger signs. You have to really investigate further if the patient comes with any of the symptoms I'm going to talk about. Those are red flag symptoms. So you note them also in the ODQ. You don't downplay red flag symptoms. Very good. And so on this slide, let's look at the danger signs of headaches I was talking about. Now, there is a very common popular mnemonic for this, known as SNOOP 10. SNNOOP 10. It means 10 P's. So let's quickly run through them. So the first S is for, or S stands for systemic symptoms, including fever. So if someone has got headaches and then fever, you should be considering conditions like a possible meningitis, encephalitis, probably cavernous sinus thrombosis, cerebral abscess, etc. If the patient has, N stands for neoplasm history. So if the patient has cancer, there could be a possibility that probably he has had a metastasis to the brain, and so you need to also be on the lookout for that. Then neurological deficits, even including a reduced GCS or an impaired consciousness level, that can indicate a possible stroke, a possible subarachnoid hemorrhage. Then O stands for onset, which is sudden or abrupt. So if you have headaches with sudden onset, you should be considering stuff like subarachnoid hemorrhage. Then the next O is older age. If you have a patient who has headache with onset more than the age of 50 years, you should be considering, and probably she's a female, you should be considering conditions like giant cell arteritis. Okay, then we have P. The first P stands for pattern change or recent onset of new headache. So probably the patient has been having very benign headaches, and then currently he has this headache which has a new pattern, very severe, has a new pattern. You need to investigate it because it could be a secondary headache. Then the second P stands for positional headache or postural headache. And so whenever a patient changes his position abruptly, let's say the patient was supine and then assumed an erect position and starts feeling these headaches, it is also a cause for concern because it may indicate a low CSF pressure headache or a CSF leak. So you need to also be on the lookout for that, positional headache or postural headaches. Now the third P stands for headache precipitated by sneezing, coughing, or exercise. This may be a sign of a raised intracranial pressure, which could be from meningitis, could be from a stroke, could be from any intracranial space occupying lesion like an abscess, a tumor. So you need to be on the lookout for that. Then we have the fourth P, papilledema, also a late finding for a raised intracranial pressure. When you do fundoscopy and then you see that the fluid around the optic disc is really a lot, that is papilledema, and you need to find out what is causing that. Then the fifth P, of course, is a progressive headache and one with atypical presentation. So you have headaches with atypical presentation progressively becoming very severe. You need to investigate for a possible underlying secondary cause. Then the next P is for pregnancy or puerperium. This could be a hypertension related problem like preeclampsia, eclampsia, or atypical preeclampsia with atypical features. You need to consider that. Then if you have a painful eye with autonomic features, you have a patient with headaches coming with a painful eye with autonomic features, you need to rule out a possible glaucoma, and so you need to be on the lookout for that. That's also a danger sign. The next P I want to talk about is a post-traumatic onset of headaches. So someone hits his head against the wall and then starts complaining of headaches afterwards, particularly if the site of impact is on the temporal region. You can have epidural hematoma, very, very dangerous, and so you need to consider that. Then if the patient has a pathology of immunosuppression, the patient is having any immunocompromised state, maybe the patient has a malignancy, the patient has HIV and AIDS, comes with headache, it could be CNS toxoplasmosis, it could be a brain tumor, so you need to be on the lookout. If a patient with immunosuppression, maybe he's on immunosuppressants, comes with headache, you need to find out what the cause is. Then if the patient has been using painkillers, painkiller overuse, it's also a cause for further investigation. So these are the danger signs, a few danger signs you need to be on the lookout for when a patient comes with headache. Snoop P10. Very good. And so although I have mentioned this already in another way, I want to reiterate that whenever you are evaluating a patient with headache, the first question you're asking yourself is this headache a primary headache or a secondary headache? That is the first question. And the next question is, if it is a secondary headache, are there any symptoms which suggest a serious underlying cause? And so, like I said earlier, primary headaches are usually recurrent, and so a simple question asking whether the headaches have occurred before can be a crude way to differentiate between a primary headache and then a secondary headache. And so again, when evaluating a patient with headache, your first concern is this a primary headache or a secondary headache? And are there any red flag symptoms suggesting a possible serious underlying cause which needs immediate investigation and a possibly immediate intervention? That is your concern as an evaluator, as it were. Very good. And so when taking the history, I have mentioned this tool before. This tool is called Illness Script. When taking the history, like I said in the ODQ, you need to ask relevant diagnostic questions and risk factors which would suggest that maybe subarachnoid hemorrhage or migraine is responsible for this patient's headache. And so we employ the illness script. Like I said in the very first video we started on this channel, the illness script is a group of sentences or just a single sentence which spells out the signs and symptoms plus the risk factors and complications of a condition. Okay, so once you have this, you have the illness script of the condition. You can always write illness scripts for various conditions so that you can know their diagnostic symptoms and then start asking patients if you think they have those conditions. And so I'm going to write illness script for a few of the differential diagnoses we have generated with our mnemonic. Then you can do the rest on your own. So I'm going to begin with migraines. So what will show that this patient has migraine? Traditionally, there is a mnemonic for migraine. I don't know whether any of you has come across this or have come across this mnemonic. It is called the pounding of migraine. Pounding, the pounding of migraine. And so the P there stands for pulsating. pulsating or throbbing. It means that the pain of migraine is usually pulsating, it's throbbing, it's not constant. And O stands for the onset, onset of headaches. Okay, and the onset is usually gradual, and it can last for as long as 4 hours to 72 hours. That is very typical for migraine. When it starts, it's very throbbing, and then it lasts between 4 to 72 hours. And then the U stands for unilateral. So migraine is typically unilateral, affects, or the pain is usually on one side of the head, although it can be bilateral occasionally. And then the N there stands for nausea and vomiting. But again, we include other associated symptoms like photophobia, they hate to look at light, sonophobia, they hate noises. And then some literature like Merck's manual even document osmophobia. Now, osmophobia is hatred or dislike for strong odors, because strong odors also worsen their headaches, so they don't want to be around strongly scented materials. So nausea, vomiting, photophobia, sonophobia, osmophobia. Then the D stands for debilitating or disabling. The pain of migraine is very severe that the patient is disabled. If the patient is maybe doing something and then he has an attack, or she has an attack, he stops everything he's doing and he wants to go and lie down. Okay, so we'll continue the other features on the next slide. Now, another feature that characterizes the headache of migrainous origin is that it is worse on activity. And so because they have photophobia and phonophobia, and then the headache is is made worse on activity and exertion, these patients would prefer to be in a dark, quiet place. They would want to be in a dark, quiet place because one, dark, they are photophobic, quiet because they are sonophobic, and they want to rest because the headache is worsened by activity. Now, about a quarter of patients who have migraine come with aura, an antecedent group of symptoms which precedes the headache, and then the aura of migraine is usually visual. So they see these lights, zigzag lights, even before the migraine occurs. And please note that the aura is just with 25% of patients. About 3/4 or 75% of patients do not have aura with a migraine. Then the typical migrainous patient is a female. So females usually have the migraine, although it can occur in males, and the age of onset is usually during puberty. Okay, and then by age 50 or so, it abates, it vanishes. They don't have these migraines again. And also very important is the fact that there may be a positive family history of migraine. And so really this is the brief illness script for migraine. So the illness script I want to summarize: a typical patient will be a female patient with a headache starting during puberty, or it may start longer than that. They may have a pulsatile headache. The onset is gradual and it lasts between 4 to 72 hours. It is usually unilateral, and then they have an associated nausea, vomiting. They like to sleep in dark, quiet rooms because they are photophobic, they are sonophobic, and then the headache is worsened on activity. Only a quarter of them would have lights, visual auras preceding their headache, so they can predict when the headache is coming. And then there may be a positive family history. And also very important is the fact that the headache is usually disabling or debilitating. The next type of headache we want to see is the tension type headache. Now, like I said early on, tension type headache is the most common cause of headache. If a patient comes to you complaining of headache, your best guess is that this patient probably has a tension type headache. So it is usually bilateral as against migraine, which is what? Typically unilateral, and it is non-throbbing. So migraine is throbbing, tension type is not throbbing. And then it is pressure-like or band-like. Okay, so it occurs as a band, and sometimes it radiates from the occiput, the back of the head, forwards. And unlike migraines, there are no associated features. So the patient wouldn't complain of phobia to light, or phobia to sound, or phobia to odor, or maybe feeling nauseous or having the urge to vomit. No. So typically tension type headache has no associated features. So the pain is usually constant in nature, and it is very frequent. It is very frequent, and for the intensity, you can have mild to moderate intensity usually, but occasionally it can be very severe in intensity. You have anxiety or emotions, or sometimes alcohol binge precipitating the tension type headache. And so you weigh it against migraine, and you see that they have, they are diametrically opposite. Okay, the next type of primary headache we want to look at is one of the trigeminal autonomic ephalgias, that is cluster type headache. So the cluster headache, unlike the tension type headache and then the migraine, they are relatively uncommon. So in this group, the patient usually experiences multiple unilateral orbitotemporal attacks. To break this down, what we are saying is that the cluster headache shares some features with the migraine, such that it is unilateral, okay, and then the site is usually periorbital around the eyes and then getting to the temple, okay, the temporal region. That is where the headache usually is located, and then the patient keeps having multiple attacks, okay, multiple attacks, and then these attacks have the same features, the same characteristics, and very interesting is the fact that they occur often at the same time of the day, and that is in fact the origin of the term cluster. They have this cluster of headaches, okay? So the patient tells you that, see, this pain, I had it 6 p.m. yesterday, 6 p.m. 2 days ago, and today too I'm having it at the same time, all right? And then typically, like migraine, it is very severe, and it is deep-seated. The patient tells you that although it is in the periorbital region and the temporal region, he feels it inside, and it is unilateral. Just that unlike migraine, this type of headache doesn't last for 4 hours to 72 hours. No, it is typically brief or relatively brief, between 30 and then 90 minutes or 180 minutes. And so the contrast is that, or the similarity with migraine is that it is unilateral, it is very severe, but the contrast is that it occurs on the same time of the time of the day, and then it is deep-seated, and unlike migraine, it is relatively short period headache. It's a short period headache. Still on the cluster headache, just like migraine, it's also associated with other symptoms, okay? So cluster headaches can be associated with lacrimation. So the patient complains of teary eyes, nasal congestion. All these are autonomic symptoms, okay? Lacrimation, nasal congestion, Sometimes they can complain of reddened eyes. And occasionally, patients with cluster headache present with Horner's syndrome features. So these include anhidrosis, so they have reduced sweating on that part of the orbitofrontal region, which is painful. They have meiosis. When you examine them, you see that their pupils are constricted, and they have ptosis, okay? They have drooping eyelids. All these are features of Horner syndrome. And so the association, lacrimation, nasal congestion, all these are autonomic symptoms, red eye, and sometimes Horner syndrome. Now, unlike migraine patients or migrainous patients who would like to go and sleep, rest in a very quiet room, these patients would like to pace about during attacks. It is so severe, so painful that they can't sit at one place. They are very restless, so they pace about. And then a very sharp contrast again here is that whereas the migrainous patient is typically a female, the cluster headache patient is typically a male. And then the headache usually starts at the age of 20 to 40 years. Okay, so you can see a lot of contrasting features between migraine and then cluster headache. But of course, when it comes to the two most common types of primary headaches, it is either tension headache or migraines. But just that the cluster headaches share some similarities with migraines, and of course some profound differences from migraines. So I hope this helped with the primary headaches. Very good. And so on this slide, let's begin to write some few illness scripts for a few of the secondary headaches. We want to begin with meningitis. What is the illness script for meningitis? So these patients would present with non-specific headaches. They don't have any specific feature. They just present with headaches. And this headache may be worsened by cough or straining, indicating a possible raised intracranial pressure, headaches of raised intracranial pressure. There would be fever, neck stiffness. The patient may have seizures, and then the risk factor is that this patient may have traveled to a meningitis endemic area in Ghana. You are talking about the north, in a very dry weather condition, or the patient may have been in contact with another individual with symptoms suggestive of meningitis. There would have been, or there could be, an antecedent coryzal symptoms. This patient may have had some respiratory tract symptoms. Okay, so these are the few illness scripts we got here. Then the next I want to talk about is subarachnoid hemorrhage. And so what is a typical subarachnoid hemorrhage illness script? So these patients they are typically older. They have this headache which is sudden in onset, and the site is usually occipital, although it can occur in the frontal region. And then very striking is the fact that this type of headache peaks in intensity within seconds of onset. That is how come they describe it as thunderclap. So they have these headaches, and then suddenly it just peaks in intensity. They've never had that before. So that is a thunderclap headache, and they describe it as the worst headache of their lives. These patients may have seizures. They may have a history of loss of consciousness when the attack came. Of course, a patient with subarachnoid hemorrhage, they may have a history of hypertension, and some of them may know that they have polycystic kidney disease, autosomal dominant polycystic kidney disease, ADPKD, or there may be a family history of ADPKD. All right. The next secondary headache I would like to talk about is sinusitis. So quickly, these patients may have an associated coryzal symptoms. They may also complain of facial pain. Now, it could also be due to dental or ear infections. And so these patients may come with earache, toothache, ear discharge, fever, malaise. It could be from cavernous sinus thrombosis, although very rare. I decided to talk about it. So these patients will come with very severe headaches. They would have double vision or diplopia, and then it is from abducens nerve palsy. So that is a patient with cavernous sinus thrombosis. And then there may be other secondary headaches like cerebral abscess. These patients may come with fever. They may come with focal neurological deficits. It may be as a result of strokes. These patients may come with headaches with reduced or impaired consciousness level. They may come with slurred speech, and then unilateral sided weakness. Okay, so in the next slide, I just want to talk a little about cavernous sinus thrombosis, and then that should be about it for this brief lecture. And so a little about cavernous sinus thrombosis. Yes, so this occurs when you have any infectious process going on in the danger triangle of the face. And so this is a danger triangle of the face. You have the root of the nose, all right, the root of the nose, and then the angles of the mouth. If you join these points together, you have the danger triangle of the face. If you have any infections here, these infections can be translocated into the cavernous sinus. The diagram on the right shows the intracranial cavity with some of the venous sinuses here. Now the black arrow points to the cavernous sinus, and then this sinus receives venous drainage from the ophthalmic veins, and these ophthalmic veins are also facial veins which drain the face. And so if you have any infectious agent or infectious process going on in the danger area of the face, some of these can become you can have septic emboli, which will be thrown into the cavernous sinus and will cause thrombosis there, and then that would cause cavernous sinus thrombosis. Now they would have abducens nerve palsy because the abducent nerve runs through this cavernous sinus, and so when there is thrombosis, there is irritation of the contents of the the cavernous sinus, and then one of them is the abducens, and since the abducens nerve is responsible for supplying the lateral rectus muscle of the eye, that lateral rectus will be paralyzed, and so there will be two images formed on the retina of the patient, and that will cause diplopia. And then this condition is very fatal. It has a very high mortality, so it should be considered fast and then dealt with promptly. And so this is the end of the patient with headache, the brief lecture. If you like this content, again, kindly support the channel by liking and sharing this video, subscribe to our channel, and please do not forget to turn on your notification bell so that when we post new videos like this, you can have access to them. Thank you for watching once again. My name is Dr. Obeng-Frimpong. Have a great day. Bye.